Okay, so I would just like to demonstrate the cricoid pressure and burp maneuver on this model. So as you can see, over here you've got your thyroid cartilage with the laryngeal prominence that forms the Adam's apple. In between you have your cricothyroid membrane or your cricothyroid ligament, and below that is your cricoid cartilage. Now, if you are performing cricoid pressure for a rapid sequence induction and intubation, you shouldn't be doing anything else except this. So you will be the designated cricoid pressure person. You will tell the patient beforehand what you're going to do and explain to them that you will just lightly keep your fingers on the spot until they fall asleep, and after that you will press harder. So once they've fallen asleep, you press as hard as to turn the fingertips white, and you only release the cricoid pressure when the person that is intubating tells you that they are happy that the tube is in the right place. The burp maneuver, or backwards, upwards, rightwards pressure, is a way to improve the laryngeal view for the person that is intubating. So that is done on the thyroid cartilage. It doesn't need to be done with 2 fingers. You can use a few more fingers. But basically you push backwards, upwards, and to the patient's right. So you basically bring the vocal cords a bit into better view for the person intubating. So again, backwards, upwards, and to the patient's right. That is how the burp maneuver is performed. Again, if we look at it on this model, you will see that you can see the laryngeal prominence, or the Adam's apple of the thyroid cartilage. So you will feel below that, in between the cricothyroid membrane or cricothyroid ligament, and below that you feel your cricoid cartilage. And that's where you would put 2 fingers, pressing lightly until the patient falls asleep, and then pressing as hard as to turn the fingertips white. And then again, your burp maneuver is performed on the thyroid cartilage, so it backwards, upwards, and to the patient's right. All right, so let's just talk a bit about how we size some of our airway equipment. So this is our OP airway, or our oropharyngeal airway, and it comes in different sizes. We want to size it against the patient's mouth to measure the distance from the mouth to the angle of the jaw. Now the angle of the jaw is right there where you can see the jaw is forming that angle. And you can see that this is the correct size for this patient, because you're sizing it as you want this oropharyngeal, or what you want it to do. You want it to bypass the soft tissue in the base of the tongue and want to make, in order to form a clear open airway for you from the patient's mouth into their throat. When it comes to the masks, you want it to fit in a way so that it does not press on the eyes. So you will see this way this mask is fitting. It's not pressing onto the eyes. It's fitting nicely over the bridge of the nose, and it's fitting nicely on the chin. It's not overhanging the chin, because that would make it too big. And if it's too small, it won't fit over the bridge of the nose. It will actually, sit on top of the nose like that, and you will not have a seal here. So this mask actually fits quite nicely for this patient, and you'll see that the patient has got the perfect size mask now. When we talk about our nasopharyngeal airways, so this is what they look like. All right, so we size them from the patient's nostril to the tip of the earlobe. Now this one is a bit too big. You will see it's overhanging. It should actually just reach there to the patient's earlobe from the patient's nose. So this one is too big for this patient. As you will see, it's overhanging like that. How do we insert the oral airway? Well, there's 2 ways you can do it. You can you need one hand to open up the patient's mouth, and then you insert it with this side first. So you gently insert it just until you feel that you're reaching the hard palate. Then you turn it all the way around and you advance it all the way down like that. So I can just show you again. Obviously I've got one hand holding the camera, but you'll use the other hand to open the patient's mouth. Then you insert it basically the wrong way around. So that curved part going that way, and when you've reached the hard palate, you turn it around and you advance it into the patient's mouth. And the idea why we're doing this is because we actually want to try and prevent any damage to the patient's lips or to their tongue. So the purpose when you insert it is obviously to be very careful, and just as you feel you're reaching the hard palate, don't damage the hard palate or the soft palate. You just gently turn it around and you advance it all the way down like that. All right. The other way that you can insert it, if you have something that's going to press the patient's tongue for you out of the way, so you can use a tongue depressor blade or you can use a laryngoscope blade. So if you have something that you can use to press the patient's tongue down and out of the way, then you may insert the oropharyngeal airway the right way around from the start. Okay, just want to show you a bit what our normal endotracheal tube looks like. So here it goes. It's got a connector at this end. And then you see you've got all the writings on the side here. That first writing there tells you the size of the tube, which is 6.0 millimeter. That's the internal diameter of the tube. And that's what we use to refer to when we talk about the size of the tube. And then it gives you your centimeter markings. You'll see it goes 26, 25 and all the way down to about 16. And these are the centimeters markers that we look at when we have inserted the tube and we're happy that it's in the right place. We note where the mark is sitting in the patient's mouth. So for instance, if we've now just, roughly intubated this patient, and now we see, okay, we're happy that we're in the right place, we're ventilating both sides, then we note that 18 is sitting here by the patient's lips, and we note that as that is where the tube is inserted to, and the tube is strapped by keeping that at 18 centimeters here at the patient's mouth. Okay, you'll also see lower down that you've got your, again, it ends at 16, and you'll see here that there's an 8.2 that actually refers to your external diameter, which is 8.2 millimeter. But again, the internal diameter, or the 6.0, is what we use to talk about when we talk about the size of the tube. The Mallinckrodt, that is just the company that manufactures this tube. And you'll see this kind of blue line that goes all the way up. That's a radio-opaque line. So this will show up on a chest x-ray so that you can follow on a chest x-ray, follow the whole ET tube down. You'll see here that you've got two black marks. So that's to help guide you when you are inserting the tube. Because when we insert this endotracheal tube, we want this cuff to sit below the vocal cords with your tip of your tube sitting above the carina. Okay, so this is a kind of visual indicator that helps you to achieve that. So as you insert this through the vocal cords, you want the first black mark to go through the vocal cords and this black mark to sit outside the vocal cords. So you basically have this space that will be sitting between the vocal cords, and then you can stop advancing the tube. Here you see your cuff, and obviously here is your pilot balloon that you use to inflate that cuff with. Now you'll see, if you look at this tube, you've got two openings. You've got the big opening on that side, but then also on this side you've got another opening there. So that's your Murphy's eye. That's your normal opening of your ET tube, and there's your Murphy's eye. And the purpose of the Murphy's eye is for the following. If you inserted your tube just too deep and it's sitting right onto the carina, you will still be ventilating the left lung with this opening and the right lung with Murphy's eye. So if I can demonstrate, so say for instance, you've intubated this patient now, and you'll have to imagine you're coming all the way down now, and you've managed to just put this tube straight onto the carina. You'll see now that left will be ventilated by that opening, and the right will be ventilated by your Murphy's eye. Okay, so just to talk a bit about the different types of LMA, or laryngeal mask airways, that we have. So we get first generation and second generation, and obviously there's different makers of the LMA, so they might look different from each other. So the first generation LMA only has one tube that you use to ventilate the patient through, as you can see here. It also has a cuff that you can blow up to get a better seal with this bottom part of the LMA. And you will see that it's got sizing numbers on the side, and this sizing is going according to weight. So you'll see for an adult that's 70 to 100 grams, this will be a size 5. And for instance, this is a size 4, so this manufacturer has designated it for adults between the weight of 50 to 90 kilograms. Right. So this is your first generation LMA, so only has one tube through which the patient can be ventilated. And when we insert it for patients, it's important that we lubricate it well. So we lubricate this side and we lubricate this bottom side as well. And you always insert it with the writing side towards you, and you use your other hand to open the mouth, and you insert it all the way down until you meet resistance, and then you should have your LMA sitting nicely over the vocal cords and be able to ventilate the patient through there. Again, it's inserted blindly, so all you need is another hand to open the patient's mouth and then inserting it all the way down until you meet resistance. Your second generation LMA, this is an example of a second generation LMA. So you'll see this one has got 2 holes. So that one is the one you use to ventilate the patient through. This one is an extra gastric tube. It opens up here at the bottom, so it can allow air to escape from the stomach, and you can also put a small suction catheter down to suction any secretions. So this is an example of a second generation LMA. Again, you would lubricate it nicely on this side all the way down. You would hold it with the writing facing towards you, use your other hand to open the patient's mouth and insert it all the way down until you meet resistance, and then it should be sitting nicely over the vocal cords. Okay, I just want to show you guys the technique as to how we hold the mask when we bag mask ventilate patients. Again, you need a mask that fits properly, and you'll see this one is a good fit for this patient. So this is your EC way of holding the mask. You'll see these 2 fingers is forming a C, and this C I need to press the mask down onto the patient's face, so in order to prevent any leakage, so to have a nice seal. And you'll see this part of this soft part of my fingers and thumb also needs to be placed on top of this mask. It's not just the fingers like that, it's actually this whole part of my hand and my thumb and index finger. So this C, I need to push the mask down. Then these 3 fingers will form the E, and this I need to actually just do the jaw thrust. Okay, so the C to push down, and these 3 fingers is performing the jaw thrust and lifting the patient's jaw up. So you'll see I've got my pinky there under the angle of the jaw, that's doing my jaw thrust, and I've got the other 2 fingers also on the jaw, on the bony part of the jaw, hooking it on the bony part, and that I'm using to do my jaw thrust, and my C I'm using to push down the mask. All right, you can do this with 2 hands, and obviously my one hand that's holding the phone will also be on the mask forming an EC, and then you need someone else obviously to be bagging the patient. You can use another 2-handed technique with your thumb pushing down on the mask like that, and all of your other fingers hooking around the angle of the jaw so you can do a jaw thrust. Obviously you'll just also be using your other hand, which is now holding the camera, but using your thumb to push the mask down and the other fingers to do the jaw thrust. If you do that with a 2-handed technique, that actually works quite well, especially if you've got small hands.